Good morning, dear students. This is the first lecture in biochemistry of the reproductive system. We will talk about the male reproductive system in this lecture. The objective of this lecture to state the mechanism that regulates the hypothalamic pituitary testicular axis in the male, and then we will understand the biosynthesis of testosterone, the major androgen, and the metabolite of testosterone, how it is transported, and the metabolism of testosterone. Then we will describe and learn how to interpret the result of different biochemical, hormonal, and endocrine tests that is performed in the investigation of any clinical cases related to the male reproductive system. The function of the testis is two main functions. First of all is to synthesize the sperms in a process called spermatogenesis, and the second function is to produce the androgens, the male hormone. The most important one is the testosterone. The two most important cells that play a role in these two processes is the Sertoli cell and the Leydig cell. Leydig cell produces the hormone testosterone, and this process occurs under the control of the luteinizing hormone, while the Sertoli cell produce or provide the other cells that is found in the testis with a nutrient, and also produce several regulatory proteins, which are very important protein. The most important of these regulatory protein that are produced by the Sertoli cell, we have the inhibin, the activin, the AMH, or what is called the anti-Müllerian hormone, and we have also the androgen binding protein. So this is the function of the Sertoli cell. And the Sertoli cell function is usually under the control of the follicle stimulating hormone, the FSH, from the pituitary gland, while the Leydig cell produce the testosterone. Inhibin that is produced by the Sertoli cell is its nature is a glycoprotein, and its main function is to inhibit the pituitary secretion of FSH, the follicle stimulating hormone. Many androgens are found in the human male, but the most important one is the testosterone. So what is the function of testosterone? It is important for the early sexual differentiation during embryogenesis, and also it's important for the production of sperm in the process of spermatogenesis, and at puberty it's important for the promotion, the start of, and the maintenance of sexual maturity, and even later on in adulthood also it is important for the normal sexual acts. The entire hypothalamic pituitary testicular axis must function normally for spermatogenesis. First, we start from the gonadotropin releasing hormone, which is a protein or a peptide that is synthesized in the hypothalamus, and it is a releasing hormone. Then it will pass to the pituitary gland and stimulate the release of two gonadotropin, which are the follicle stimulating hormone and the luteinizing hormone. The secretion of the gonadotropin releasing hormone and subsequently the gonadotropin occur in a pulsatile pattern. What do we mean by this? It means that it is not the concentration, it is not constant throughout the day. There is time in the day where the concentration of these hormones increase. For example, in the early morning, the concentration of these gonadotropin releasing hormone, luteinizing hormone, and the follicle stimulating hormone will be increased, and then it will decrease at the evening. So this is meant by the pulsatile pattern of secretion of the male hormone. It is not constant throughout the day. The secretion of luteinizing hormone is under a negative feedback control from the final product, which is the testosterone, while the release of the follicle stimulating hormone is inhibited by inhibin and stimulated by activin. Both of these proteins are secreted by the Sertoli cell. Luteinizing hormone, once it's secreted, it will stimulate the production of testosterone from the Leydig cell by starting the first step in the production of testosterone, which is the conversion of the cholesterol to a pregnenolone. While the FSH, while acting on the Sertoli cell, it will stimulate the spermatogenesis. Whenever we have a disease that will lead to decrease in the number of Sertoli cell in the testis, for example, if there is severe infection that will lead to fibrosis, or when we have our testis is exposed to radiation or certain surgery, whatever the disease that affect the testicular tissue and lead to decrease in the number of the Sertoli cell, this will decrease the inhibin, and as a feedback mechanism there will be increase in the secretion of the follicle stimulating hormone from the pituitary gland as a compensatory mechanism, trying to compensate for the decrease in the number of Sertoli cells and to compensate for its action. So any disease that decreases the number of Sertoli cells will lead to a compensatory by negative feedback. It will lead to increase the production of the pituitary follicle stimulating hormone. While any disease that decreases the number of the Leydig cell in the testis, also for example by surgery that lead to destruction of the tissue, or when for example a certain infection like mumps, orchitis, or for example radiation, exposure to a high dose of radiation that will lead to destruction of the Leydig cell. This will lead to decrease in the production of testosterone, and as a compensatory mechanism and by a negative feedback, this will lead to increase in the concentration of the luteinizing hormone and increase the secretion of luteinizing hormone from the pituitary gland. The source of testosterone is two main, which are first the testis, the Leydig cell of the testis, which synthesized about 95% of the testosterone, اللي هو النسبة الأكبر synthesized by the Leydig cell of the testis, and we have a little contribution, about 5% from the peripheral conversion of other androgens, for example the dihydroepiandrostenedione from the adrenal cortex and androstenedione also, and they can be converted and to the testosterone. Synthesis usually started from the conversion of cholesterol to a pregnenolone. In this step, this is the first step in the synthesis of testosterone in the testis, and then we have many steps and intermediate before the conversion of pregnenolone to the final product, which is the testosterone. Cholesterol is converted to pregnenolone, then this will be converted to 17-alpha hydroxypregnenolone, then to dihydroepiandrostenedione, to androstenediol, and later by the 3B hydroxysteroid dehydrogenase it will be converted to testosterone. This is the main source of the production of testosterone in the human male. Deficiency of any of these enzymes may lead to a decrease in the product in the next step and accumulation of the substrate in the previous step, and this will lead to alternative pathway that will lead to a different product. So it is very important to, in order to have a normal level of testosterone, to have all the level of these enzymes are normal. Deficiency in any of these will lead to decrease in the production of testosterone and accumulation of the product in the steps before the defect enzyme, and these substrate may enter into alternative pathway and lead to production of different products. In the circulation, about 97 to 98% of the testosterone is bound to a binding protein, and about 2 to 3% is free. The binding protein are either specific, which is the sex hormone binding globulin, or could bound weakly to non-specific protein as the albumin. About 60% of testosterone is bound to the sex hormone binding globulin, and about 38% is bound weakly to the albumin. The difference between these two proteins in the binding capacity and the affinity is that the testosterone will bound to sex hormone binding globulin with very high affinity, the strong binding between the sex hormone binding globulin and the testosterone, but the capacity of the sex hormone binding globulin for testosterone is low. On the opposite, the albumin has high capacity for binding to testosterone, but the binding is weak and we call it low affinity. Because the binding between the albumin and the testosterone is weak, so it can be rapidly or easily dissociated from albumin. So we considered that the biologically active fraction in this case of testosterone include both the free testosterone, which is already available in the circulation, and the albumin bound testosterone. Why? Because of the weak binding between these two, so it can be dissociated and can be used. Totally, we say that the free is about 2 to 3%, but if we measure or count the biologically available testosterone that is bound to albumin with it, the percentage of the bioavailable testosterone will increase to about 30% of the total quantity. What is the impact of binding between the androgen and sex hormone binding globulin? Any factor that affect the concentration of the sex hormone binding globulin will affect the level of testosterone in the circulation. For example, we have certain factors that increase the level of the sex hormone binding globulin. For example, hyperthyroidism, liver disease also will increase the concentration of the sex hormone binding globulin. Certain medication, for example, the estrogen and anticonvulsant, also will increase the level of the sex hormone binding globulin. Excess alcohol also will lead to increase in the sex hormone binding globulin, and eventually it will affect the level of the testosterone. While certain factor will decrease the level of sex hormone binding globulin and will affect the level of testosterone, and we must put in mind these factors when we interpret the level of low testosterone or in patient with obesity or hypothyroidism, in case when we have a high dose of steroid medication. In case of insulin resistance, also this will lead to decrease in the sex hormone binding globulin, and when the level of prolactin is high in hyperprolactinemia, this also will lead to decrease the level of the sex hormone binding globulin. The metabolism of testosterone. Testosterone can be converted by two enzymes, which is the 5-alpha reductase and aromatase, to two different compounds. The 5-alpha reductase can convert the testosterone to the more potent androgen, which is the dihydrotestosterone. So the enzyme that converts the testosterone to dihydrotestosterone, the potent androgen, is the 5-alpha reductase. And this product, the dihydrotestosterone, is very important during the embryogenesis. It is form the primary sex character during embryogenesis. During the puberty, it will form the secondary sex character, and in adulthood, it is responsible for the male sexual function. So, dihydrotestosterone is a product from the testosterone by the enzyme 5-alpha reductase, and responsible for the production of the primary sex character during embryogenesis, secondary sex character during the puberty, and it's in adulthood it is responsible for the adult male sexual act. The other compound that the testosterone can be converted to is the estrogens by the enzyme aromatase. The dihydrotestosterone mainly converted from testosterone in the certain organ, which are the prostate and the skin, while the conversion of testosterone to estrogen by the process of aromatization by the enzyme aromatase usually occur in the liver and the adipose tissue. This means that whenever there is increase in the fat percentage in the body, when there is increase in the adipose tissue, this means that the conversion of the testosterone to the estrogen will increase. Why? Because the aromatase enzyme is present in high concentration in the fat cell in the adipose tissue. So whenever the person have increase in the adipose tissue mass, this will lead to more conversion of the testosterone to the estrogen. Later, the dihydrotestosterone, the potent androgen, is metabolized to another compound, which is the 3-alpha androstenediol. Then this, by conjugation with the glucuronic acid, it will be converted to 3-alpha androstenediol glucuronate. And these two compounds, the 3-alpha androstenediol and the 3-alpha androstenediol glucuronate, can be used as a marker in the circulation of the activity or the quantity of the dihydrotestosterone. So these are the metabolite of the dihydrotestosterone and can be measured as used as a marker of the production of the dihydrotestosterone. Later on, these all can be converted to certain steroids called 17-keto steroid and excreted in the urine. All these can be converted later to the a group of steroid called 17-keto steroids, and the body get rid of them by their excretion in the urine. Testosterone concentration is not fixed throughout all stages of life. What is the importance of knowing this fact is that it is very important during the interpretation of the level of testosterone in different stage of life. For example, it starts for the first time to increase during the embryonic life at the 7th week of gestation, and start to increase from the 7th week to the beginning of the second trimester, which is about the first, each trimester is 14 weeks. So at the beginning of the second trimester, it will be reach the peak of its level during the fetal life. Then after that, the concentration will decline until it will return to the baseline at birth. After birth, it will remain low, but start to increase when the baby is 2 to 3 months, start to increase. But after that, by the age of 6 to 12 months, it starts again to reach to its baseline level. So the first one in the 7th week and reach peak in the beginning of the first trimester of life. The second peak after 2 to 3 months of life, and return to baseline by 6 months or 12 months of life. Then the major increase in the testosterone occur in puberty. So between the first year of life and until puberty during childhood, at all these periods, the level of testosterone will remain low. Then at puberty, it starts to increase to there will be a very marked increase in the concentration of testosterone. Then it will remain high from puberty throughout the adult life. The concentration of testosterone remain high, so that when we measure the level of testosterone at each stage, for example, at the age of 5 years, we must interpret it and know the normal value that differ from the concentration of testosterone, for example, at the age of 16. This is very important to make a good diagnosis. And after the age of 30 or 40, the level of testosterone in the male start to decrease again. So all these are the peak and the low level of testosterone concentration. Then there is about decline, a fixed percentage of decline in the concentration of testosterone with each year. It has been estimated to be about 1.3 to 1.5% decrease. كل سنة the level of the testosterone in the blood will decrease after the age of 40 to about 1.3%. This occurs by decrease in the number of the Leydig cell, which produce the testosterone, or decrease in the releasing hormone from the hypothalamus. The gonadotropin releasing hormone pulse amplitude will decrease, so either the cause in the hypothalamus, the stimulus will decrease, or the number of the cell that produce testosterone already will decrease, or we have increase in the level of the sex hormone binding globulin. All these will lead to decrease in the level of the testosterone. The seminal fluid is a liquid or a semi-gelatinous cellular suspension containing the male gamete or the sperms, and also it contains the secretion from the accessory organ of the male reproductive tract. The fluid portion of this suspension, which is formed at the ejaculation, is called the seminal fluid or the seminal plasma. The semen consists of two parts, which is the solid part, the spermatozoa, and the fluid, which is the seminal plasma. One of the markers of in any case, to assess the male reproductive health is to measure the seminal fluid. In this measurement, we depend on many parameters. It will include the ejaculate volume, the volume of the fluid that is ejaculated, the pH of the fluid, the sperm count, the sperm motility, and the forward progress. All these considered as an important or baseline marker to assess the quality of the seminal fluid. This table will show the minimum acceptable level to consider the seminal fluid of good quality, in which the minimum volume of the ejaculate must be 1.5 ml. The minimum volume must be 1.5 ml. The concentration of the sperm per ml must be 15, at least it must be 15 million sperm per ml. And within the total ejaculate, the concentration of the sperm must be at least 40 million per ejaculate. The sperm, some are motile and some are immotile. So to consider this fluid of good quality, at least 40% of the seminal of the sperms must be motile. 40% must be motile. And the progressive motility, some of them are rapid progressive, some of them are slowly progressive, some are even they are rotating at their side. So the progressive motility, whether both rapid and slow, must be at least 32%. The pH of the fluid must be basic, 7.2 to 8, and any change may indicate that there is infection or any other disease. The color, either white or gray or yellow. Any other color is not accepted. For example, a red color means that there is bleeding. The percentage of the sperm that is alive within the sperm, within the seminal fluid sample, must be at least 60% of the sperm. At least 60% of the sperm in the ejaculated fluid sample must be alive. Some of them are normal and some are abnormal بها تشوهات معينة. So at least 4% must be normal. This is the quality of a good seminal fluid. We depend on the volume, we depend on the sperm concentration per mil and per total ejaculate, the motility, total motility and the progressive motility. They are two different terms, motility and also the pH, the color, how much of them are alive, and the morphology of the sperm, how much or the percentage of the normal sperm morphology within the total. Biochemistry can be very useful in detecting the abnormality that occur in the male reproductive health by using the hormone as a marker of the performance. We can divide the complaint that the male may have regarding the abnormality in this system into either hypogonadotropic hypogonadism, and we will define it later, hypergonadotropic hypogonadism, or sometimes there may be defect in the androgen action, and the Genicomastia, which is the benign growth of the breast tissue in the male. The hypogonadism generally is the decreased function of the testis. We can classify it as hypogonadotropic hypogonadism or hypergonadotropic hypogonadism. This classification depends on where is the defect that lead to hypogonadism, whether it is in the testis itself or in the higher center, that means the pituitary and the hypothalamus. What is the danger of hypogonadism? First, it can occur at all age. The second thing is that if it occurs early in life, it leads to retardation or regression of the sexual development. The hypogonadotropic hypogonadism, it means that the defects occur at higher center in the pituitary gland or the hypothalamus. For example, there is radiation to the pituitary gland or surgical removal or tumor that destroy the pituitary gland, so there's no production of the gonadotropin, FSH, LH, which are required for the normal production of the testosterone by the Leydig cell of the testis, and the spermatogenesis also will be impaired because there is decrease in the FSH and LH, or sometimes even in the hypothalamus. Any disease affect the production of the gonadotropin releasing hormone, which is the first stimulus, will lead to also hypogonadotropic hypogonadism. And in this case of hypogonadotropic hypogonadism, we can know by chemical test, when we found that both the gonadotropins, the FSH, LH, and the testosterone all are low, this means that this patient have hypogonadotropic hypogonadism, and the cause is central either in the pituitary gland or in the hypothalamus. Many diseases will lead to this condition. For example, panhypopituitarism. For example, as we said, any disease that lead to destruction of the pituitary gland. For example, large tumor that destroy it, radiation, surgery, vascular injury, malnutrition, anorexia, any cause that will affect the production of the gonadotropin releasing hormone or the gonadotropin will lead to this condition, which is the hypogonadotropic hypogonadism. In all cases of hypogonadism, the testosterone concentration will be low, but the difference between the hypo and hypergonadotropic hypogonadism is the level of the gonadotropin. يعني الفرق ما بين الهايبرغونادوتروبيك hypogonadism الهايبو and hypergonadotropic hypogonadism هو الليفل of the FSH and LH. كل الحالتين راح يكون التستوستيرون level هو يكون low. and نفرق السايت of the defect هو بالhypothalamus or the pituitary راح تكون ال FSH LH low إذا كان defect in the pituitary and the hypothalamus. لكن إذا كان defect in the testis itself راح يكون level of the FSH وال LH يكون high يكون عالي والlevel of the testosterone يكون low, because when the level of testosterone is low it will give a feedback to the pituitary to increase the production of FSH and LH to reach to the normal level. So in case of hypergonadotropic hypogonadism, the level of the LH, FSH are high and the level of testosterone will be low. Any defect in the testosterone will lead to this condition. For example, if the testosterone is exposed to high dose of radiation or a severe infection that affect the testicular tissue, for example in case of mump orchitis or after chemotherapy that affect the testicular tissue, or sometimes when we have a chromosomal defect, especially the Klinefelter syndrome, sometimes there will be agenesis of the testicular tissue, or sometimes there be a defect in certain enzymes that are very important for the production of the testosterone, for example the 20-alpha hydroxylase deficiency. All these will lead to decrease in the production of testosterone, but because the higher center, the pituitary gland and the hypothalamus are normal, they try to compensate by negative feedback. They try to increase the production of FSH, LH to trying to maintain the output of testosterone to its normal level, but the problem will be in the testis itself. It cannot produce testosterone, and by biochemical test we can differentiate between these two types of hypogonadism. If the FSH, LH were high, it is hypergonadotropic hypogonadism, and if the testosterone is low, LH is low, FSH is low, it is a hypogonadotropic hypogonadism where the defect is in the pituitary gland or the hypothalamus, and it needs to further investigation, imaging study to find the cause of the defect. In both cases, the testosterone will be low. The difference is in the concentration of the gonadotropin, LH and FSH. The other abnormality when we have defect in the androgen action. In this condition, the defect is in the receptor. We have a mutation in androgen receptor gene. It is also called androgen insensitivity syndrome. Androgen insensitivity syndrome, which could be a partial or complete depending on the amount of how much of the receptor is working. So the defect in case of defect in androgen action, the problem is in the receptor for androgen. There is a mutation in the gene that is responsible for the androgen, which could be partial or complete, and this division depends on how much of the receptor is still working. The other name is androgen insensitivity. The complete insensitivity of androgen is called previously testicular feminization. The genetic of this patient is male, in which he have a male karyotype, but the external genitalia is of female. This is complete androgen insensitivity. And even he have testes, but they are found inside the abdomen. By biochemical test, how can we know that the defect in this patient is in androgen action? In this condition, the level of testosterone is high, normal or high, similar to that of a healthy male, and the LH concentration are also increased. While in hypogonadism, whether In both cases of hypogonadism, the level of testosterone is low, while when we have defect in androgen action, the level of testosterone is high, or at least it is normal, and the level of the luteinizing hormone is also increased. But the defect is that it is not working properly because there is a defect in the androgen receptor. We have a mutation, so it became insensitive to the level of androgen. We said previously that the testosterone can be converted to two important compounds, either to dihydrotestosterone by the enzyme 5-alpha reductase, and we said that the dihydrotestosterone is very important, or can be converted the testosterone to the estrogens by the aromatase. So if we have defect in the enzyme that convert the testosterone to the more potent dihydrotestosterone, which is the 5-alpha reductase, if we have certain mutation that affect the level of this enzyme, this will lead to a defect in androgen action, and the baby will be born with ambiguous genitalia. It is not very clear whether he is male or female by looking at his genitalia. And why? Because this dihydrotestosterone is very important for the differentiation during embryogenesis. How can we know by biochemical test that this patient have decrease in the level of 5-alpha reductase? This is by measurement of the level of the testosterone and the dihydrotestosterone, and we will find that the ratio of testosterone relatively to dihydrotestosterone is high. It means that the conversion from testosterone to the dihydrotestosterone is limited. So this is the diagnostic biochemical test that can allow us to suspect that this patient have defect in the level of 5-alpha reductase. He have deficiency in this enzyme. Genicomastia is relatively common, and it is the benign growth of the breast tissue in the male. Usually it occurs at 3 periods of life, either in the newborn because of the estrogen that is transported from the mother, or may occur during puberty. And the other peak of the occurrence of gynecomastia usually occur when the male is between the age of 50 to 80 years. So these 3 peaks in which we have not gynecomastia, either in the newborn baby, or during puberty, or at the age of 50 to 80 years. Generally, the cause is increase in the ratio of estrogen to androgen. So the main defect is the conversion, the ratio of the estrogen to androgen is high. Usually it is accompanied also by low testosterone, which is the main androgen. The level of the potent testosterone, the dihydrotestosterone, will be also low, while the ratio of the estrogen to androgen will be increased. So these are the characteristics of the characteristic change in gynecomastia: low serum testosterone concentration, low dihydrotestosterone concentration, and a high level of estrogen to androgen ratio. This increase in the ratio of estrogen to androgen either may be due to defect in the testis itself, whenever there is defect in the testis, so that the estrogen will be more than the androgen, or the other cause, as we said previously, that when we have increase in the body fat, the conversion of testosterone to estrogen by the enzyme aromatase will increase because it is very abundant in the adipose tissue. So when we have increase in the body fat, it will result in increase in the aromatization, increase in the ratio of estrogen to androgen. Certain pathological condition also may lead to gynecomastia, for example, in case of hyperthyroidism and in case of liver disease, because the metabolism of androgen, estrogen also may be affected by disease in these organs. We can measure the level of human chorionic gonadotropin, testosterone, estrogen, and luteinizing hormone. All will be affected, and we can use them to scan for this condition. Prolactin is important only in galactoria, which is the milk production, not very closely linked to gynecomastia. Prostate-specific antigen is a protein that is produced by the prostatic tissue. Why it is important? Because it have a diagnostic value. It can be used as a marker of a certain disease in the male. Usually it is produced by both the normal prostate tissue, and in case of hyperplasia of the prostatic tissue also this will increase, and in case of malignancy this will be also secreted in large quantity. So this protein is normally produced in a healthy male, but we depend on its concentration. Below a certain level it is normal. When it is increased, we suspect that he have hyperplasia, and when it is increased to a very high level, this is suspect that he have malignancy of the prostate. So it is a normal protein, but also can be used as a marker of disease. This is a logarithm. If we suspect that a patient have any abnormality in the reproductive system, to start with, we start usually with the seminal fluid analysis, and it's not acceptable to do it once. At least we have 2 specimens at 2 different occasions. The seminal analysis must be, if we check for it, to give a proper result must be done at least 2 different occasions. If the result of the seminal fluid analysis were normal, and by the result analysis we mean that we measure the volume, the motility, the pH, the how many of them are percentage of alive, and the color and other feature that we talked in previously in the lecture. If the result of the seminal analysis is normal, then it means that there is no need to do further hormone analysis. But if the seminal fluid analysis show that the sperm count was below 5 million per ml, we say that it must be at least 15 million per ml. But if it was less than 5 million per ml, if it is azoospermic, which there is no sperm, this indicates that either patient have obstruction in the tubules, or there is dysgenesis, in which there is complete disorganized tissue. To differentiate between these 2 conditions, if the hormones are normal, then we mean the testosterone, FSH, LH. If these are normal, then it means that the synthesis is normal, but there is obstruction to the outflow. But otherwise, it means that there is dysgenesis in case of azoospermia. But if the sperm count also was below 5 million per ml, but not azoospermic, then we measure the level of the gonadotropin, the LH, FSH, in addition to the testosterone. If all results are normal, this is idiopathic cause. But if the level of testosterone is low, while the gonadotropin is raised, this indicates that the patient have hypogonadotropic hypogonadism, and he have primary gonadal failure. The problem is in the testis. And if the testosterone is low and the LH is low, the FSH is normal or low, this indicates that the patient have hypogonadotropic hypogonadism. Either he have hypothalamic disorder, pituitary disorder, and in this case we need further investigation to the pituitary to test for other hormone. So this is a simple scheme that represents how to start testing for the male reproductive tract in case there is any abnormality. And thank you.